Going to start. Very happy to be here today. I'm Dr. Elisa Placidi, and I'm a medical physicist in Policlinico Gemelli in Rome, Italy. And today I'm going to talk about the clinical relevance of inhomogeneity, calculation in gynecological brachytherapy. So, uh, so these are my points. I'm going to give you a little introduction. Well, if you know this, our hospital is in the north of Rome in Italy. It's a bit famous because the Pope went to our hospital a couple of months ago. For radiotherapy, we have one dedicated computed tomography for the simulations, and for what we call external beam, we have variant machines. We have 4 radiotherapy machines. And we have the very latest Meridian machine, which is a hybrid machine that combines MRI and radiotherapy. So we can see the patients while we treat. And this is one of the few in the world. But today I'm going to talk about interventional radiotherapy center. So there's a particular type of radiotherapy which is called interventional radiotherapy, which involves a sort of a radioactive source which is implanted through applicators or catheters inside the patient. And so this is particularly important for gynecological lesions, because of course we can access gynecological areas through natural ways. So we can put applicators, and I will show you later. So this is a particular radiotherapy, which is interventional because it's in between surgical and radiotherapy. So this is our doctors. So normally the oncologist or the gynecologist implants the applicators in the patients, and the physicist prepare the plan, so then we can deliver the dose through a radioactive source, which is iridium-192, but I'm not gonna go too deep into these details. So for these kind of treatments, we use 2 machines. One is the HDR Flexitron high dose rate, and the other one is PTR pulse dose rate, which is a bit older, but it's still working. We also, just for the sake of it, I'm going to show you the prostate system as well. So just to show you that it's brachytherapy, it's important also in other districts. So we can treat lots of things, but of course, gynecological is the main that we treat. We also perform ocular brachytherapy. So we put a radioactive source on the plaque on the eye to cure the ocular melanoma. But I'm going to concentrate then on gynecological treatments, and this is the software, the specific software that we use, and it's called OnCentra Master Plan. And because I'm a physicist, I'll try not to bore you too much, but I'm going to talk a little about those calculation algorithms. Because, okay, so the doctors or the oncologists say, okay, we have to give this dose to our patients. And as physicists, we have to simulate that dose in the patient as more accurately as possible. And we do this thanks to this TPS, the treatment planning systems. And depending on the accuracy of the calculation, then we have an accurate treatment or not. So this is really important, because if in theory we want to apply a dose, to deliver a dose to a patient, but then in practice we are not able to deliver it, then we're doing something really wrong. So this is up to us physicists to perform. So the physics in an ideal world, we would like a treatment planning system to account for the effect of applicators, because I will show you later, but we deliver this dose to the patients by putting applicators in. So we have the applicators to take into consideration, and we have boundaries, we have different heterogeneities, because the tissues of the patients are not the same, and I'm going to show you later, because I don't know, uterus is soft tissue, then we have air in the rectum, maybe we have some water in the bladder. So these are different tissues that have to be considered. And we want to simulate all of this very quick as well, very quickly, because of course we have the patients lying there. So this is also quite different compared to traditional radiotherapy, because traditional radiotherapy, the patient just gets a CT scan, then she or he goes home, and then he or she comes back a few days later. But for brachytherapy, we implant a cervical applicator, intrauterine applicator, and then the patient, of course, stays there and waits for the treatment. So we really have to be quick. So all of this needs to be very quick. So the simulations need to be done and performed as soon as possible. So the ideal world actually means these two main assumptions. The algorithms that we're actually using are based on a document that is called TG43, and it was published in 1995, so it's very old. And it makes these two main assumptions. The first is that the patient only consists of water, and the patient is infinitely large, because it does not take into consideration the heterogeneities and the interfaces. So these two main assumptions could go well, let's say, in 1995. But now, in the era of artificial intelligence and so on, we cannot really rely on this kind of rough assumptions. This is really not enough for us. But we have to say that our TPSs are still based on these algorithms. And I'm not going to too deep in this, but this may looks complicated, but it's really easy. So this is the algorithm that calculates the dose delivered in the patient's 3D. So it just takes into consideration some geometrical distribution, but it's really not taking into consideration all the differences in our patients. This algorithm is good, let's say, because it's really easy and fast to calculate. It is accurate enough, let's say, in certain conditions. And most importantly, it has a proven track record. What do I mean? Because brachytherapy is quite an old technique. It has a long history, and there's a literature published out there with good results. And those plants were calculated with this algorithm. But then we don't take into consideration the inhomogeneities. We don't have applicator attenuation correction, and we don't have interfaces, as I was saying. So we're actually considering the patients like being made only of water. But our patients are not that ideal. This is on your right. You can see a slice of a CT scan of a gynecological patient. And of course, you see that the pelvis is not homogeneous. We have bones, we have soft tissues, we have air in the bowels or in the rectum. We have, in this case, the bladder filled with a balloon because we normally use it to fill always the same, to have the bladder with always the same volume. And then, of course, we have in the middle, you can see some little holes, and that is actually the applicator for brachytherapy. So that's the applicator in the vagina of the patient, so that we can put our radioactive source inside to cure the lesion. So the real world is not only water, and it's quite evident, and it's quite trivial. So the TG43, which is that easy algorithm, is really not enough when there's this condition here. So bones, air, shielding materials, and of course, we cannot consider a patient being infinitely large. It's not the reality. So we have, for example, not in gynecological cases, of course, but in head and neck, for example, when we treat vestibules or skin, we have air around the patient. So we have to take that into account. So maybe some situations are fine, but definitely not in those cases, and especially definitely not in gynecological cases where we have air and so on. So Already in 2012, we had the introduction of TG186, which is a new algorithms, a new formalism, which are called, and they are called model-based dose calculation algorithms. Of course, each company has its own algorithm, but there's, of course, the report trying to give recommendations for clinical implementation. So in order to use these new algorithms, we have to differentiate between these different tissue types. And we have to know the chemical composition, the mass densities, because we have to assign those parameters correctly to the air, the lung, the bones. And this is not so easy, we have to say. It's necessary, but it's not so easy because we have to contour. So the doctor needs to contour on the CT, slice by slice. And again, in the era of artificial intelligence, this sounds a bit weird that we have to spend so much time trying to draw in order to give to the physicists the possibility to assign these different mass densities and chemical composition. But this is necessary because in order to simulate properly the interaction between the radiation and the tissues, we have to know what tissues we are treating, because we know what the radiation is. So all the gamma, I'm not going to go into too deep, but we know the radiation, what we're treating with. But so then we have to know what we're treating in order to simulate it properly. So in theory, the best way is to determine the densities on the basis of CT images, but we could also, in theory, do it with ultrasounds or MRI. Of course, we need images, otherwise we cannot simulate anything. But in case you have ultrasound and MRI, you can still do it. But of course, it's quite time consuming because you have to contour and assign each kind of tissues. So in this case, you would have to contour the bones and assign the density, contour the air and assign the density, and so on. So it's actually time consuming, and we have to consider that the patient is lying there next door waiting for us to finish her plan. This is, of course, not a gynecological patient, but just to show you that sometimes there are also artifacts. In this case, it's a lip on a head and neck patient. And so this is really bad artifact. Fortunately, nowadays, our CT scans are a lot better, but it could happen that, I don't know, maybe a femoral artifact is quite frequent. So we have to take that into account. And still, again, you have to contour slice by slice and assign the specific material. Because if you don't do that, then the software will show you maybe a result, but it's going to be wrong, like it's in this case, because in this case, I didn't assign the correct material to the artifact, and the software gives you a result, but it's actually not accurate. So you cannot really treat patients with this level of inaccuracy. So 2012, I said, there was the theoretical introduction of this new recommendation, but we have still to use it clinically because we don't have also the clinical approval, and I will show you later. Also, very important is that for radiotherapy treatments, we normally the doctors say, okay, we have to give 40 grays, which is the units of radiation. And okay, of course, this is based on protocols that are performed based on literature, based on studies performed with the old algorithms, so with the TG43. So when we move to a better algorithms, it's not so straightforward. We don't just have to, okay, we now calculate with the new one. We don't care about the consequences because, as I said, if we assign properly the mass densities and so on, then the results could be very different. So we cannot just change algorithm and treat, because we have to evaluate those differences. So I'm going to show you now some references, and then I'll talk about our experience. References, because since the introduction of these new algorithms, there's been already quite a few publications, and this is one of them in 2017 in Brachytherapy Journal. It was published a retrospective analysis of high dose rate tandem and ring. Tandem is a specific applicator for gynecological treatments of the cervix. And they performed a study on 10 patients by comparing these dosimetric results. For those of you who are not into radiotherapy, the D90, D95, D100, it means the dose given to the 90% of the volume, So it's a measure for us to evaluate how much dose is given to the lesion itself. So the GTV, it means the gross tumor volume. So the doctors contour the volumes of the lesions itself, and we can treat specifically these lesions. Or AR organs at risk. So normally we have to give as much dose as possible to the GTVs, to the tumor, by sparing the organs at risk, which normally for gynecological treatments are bladder, rectum, and bowel. So these are the normal parameters, let's say, that we normally consider to evaluate our plans. These algorithms, the new ones, resulted actually in a difference in 2 to 3%. And they resulted in a reduction because, of course, we are now seeing the reality. So seeing the different tissues, especially hair. And one of their conclusion is that for unshielded plastic gynecological applicators, there could be, let's say, minimal dosimetric changes. So 2 or 3%, or at least less than 5%, which is not so much, but still not potentially wrong. So we have to, of course, get more studies with larger cohorts to fully realize the potential of these new algorithms. Another study, there's been a few. So this was for, again, for the model-based dose calculation algorithm on HDR brachytherapy, again, in cervical cancer. And they studied 7 patients with a tandem and a void. So I'll show you later what kind of intrauterine device, 1 vaginal cylinder and 2 interstitial needles. And they compared the TG43, so the old algorithm, the TG186, the new, and the Monte Carlo, which is, of course, the gold standard for us physicists, because, of course, it's the most accurate. But, of course, it takes too much to calculate, and we cannot use for real patients. But compared to the previous study that I showed you, this study here is important because they assigned air to the rectum to generate a worst case scenario. So this is important because it can happen that the rectum is not properly prepared. So we have air in the rectum. And what happens then? So these are 2 patients, 2 different patients. So it's one slice, a CT slice. You can see the applicator inside. Below that, you can see the rectum filled with a bit of air that you can see in black, and contoured with a pink line is the bladder. So we have TG43, TG186, and the Monte Carlo. And the little circles are called isodoses, which correspond to the dose delivered to the patient. So, and there's a legend over here. So the line, the blue line, it means that that area is covered by 30% of the prescription. And the 100%, the green line, is the 100% of the prescription. So normally we want to give the 100% of the dose, so the prescription, to the tumor itself by sparing the organs at risk, which, as you can see, are really close to the lesion. So we really have to spare. If we simulate only with the TG43, we see that there's a lot of dose in the rectum, for example, because the TG43 does not see air. It simulates wrong, let's say, less accurately. So while Monte Carlo on your right, you can see that that the isodoses are, it seems like they're a little blurred, but they're better simulated, let's say. But because of the air, you can see that the light blue line on the rectum, it's actually inside the rectum. So it means that because we don't have the attenuation on the air, the rectum gets more dose in that area. So in the middle, you can see that the TG186 simulates better. It's, let's say, a compromise in between the Monte Carlo, which is the best, but of course not possible to use in clinical practice, and the TG43. So it's a good compromise. And it's because it showed smaller differences from the Monte Carlo compared than the TG43. So definitely, especially when there's considerable air in the rectum, this accuracy level is needed, because otherwise the difference in the parameters are more than 5%, which is not good for clinical practice, because it's too much and it could have clinical consequences. So ACE is the algorithm, the TG186 for Electa, which is one of the companies, may be able to calculate the dose more accurately than the TG43. Another publication, just the last one, is for a liver, just to show you that this is not only for gynecology. This is not true only for gynecological implants, but this is always true. So even for liver brachytherapy, same method. Again, the TG186 calculated less dose, lower dose compared to the TG43. So this is really important in all districts for all our patients. And this means that the TG186 underestimates the dose. So this is quite important. So I'm going to show you now the results, because when we got this algorithm, even if we still can't use it for clinical routine, we wanted to try it and see to understand how it worked. So again, we have the company gets this name, the specific name, so this advanced collapse cone engine, but it's based on a TG186 formalism. In order to use it, we normally have to start by choosing a level of accuracy. And as I said, we have to assign mass densities and chemical composition by contouring manually and assigning the densities. And still, already this step is quite time consuming because we physicists, in this case, we have to contour and assign this method, these parameters to each and every one of the materials. Then, based on the active dwell positions, so normally for brachytherapy, you have to reconstruct the catheters or applicators where the radioactive source could go. And of course, we use more than one position. And the software will draw a box around all the sources. And then there's a margin that we have to consider, because we want the interaction to also to the surrounding tissues. And we have to set all these levels of accuracy, because of course you want to be more accurate, but the more accurate you are, the longer it takes. So we have to bear that in mind. And then we have each consecutive box with larger voxel sizes, because of course you cannot get the same level of accuracy for the whole of the CT image, because it would be so big. So when we go farther away from the implant, you get less accuracy, but it's from a clinical point of view, that's not a problem, because you're very far. And brachytherapy, it's good because in a few centimeters, the dose level are really low. So even if you're not accurate, then clinically, it's not that much of a problem. So these are normally we have standards and high accuracy levels. And this is just to show you the voxel sizes that, of course, are better for the high accuracy levels. But of course, you can't do that for the whole of the CT. Then once you set all the accuracy level, you then have to, this is to show you how it works. So basically the source is encapsulated inside a little steel part in order not to contaminate the patient. And so then we have the the green arrows means that the first those components that are inside the capsule. So we don't need to simulate that because it does not interact with the patient. Then there's the so-called primary direct particles in the patient. And this is very important because, of course, it's a very high contribution of the fluents. Then we have the first scatter. So after the first interaction, let's say with the tissue, and then second scatter and third scatter. So second and higher scatter components. So this is a spectrum. So it's quite complicated for the non-physicists maybe, but this is just to show you that for our source, the iridium-192, for this radioactive, we have that the blue line is the primary dose. So you can see that in the first few millimeters, the components of the primary dose is a lot higher compared to the scattered components, which is the pink line. After around 6 centimeters, you have that the scatter components are higher than the primary ones. Because of course that's decayed, let's say. So the proportion is different. But the important one is that the total dose is the the black line. He is properly simulated. So the software needs to take that into consideration because the radiation is not interacting always in the same way with everyone and with every tissue. So we have to consider these different components. And the software makes it in different steps. So there's a primary dose calculated first, then there's the first scatter, and then there's the residual scatter. So these are separated components to be calculated, and 3 different steps. So their calculations are performed sequentially, one after the other. For our algorithm, I'm sorry, I just have a little water. For our algorithm, we have the so-called CCC approximation, so the collapsed cone approximation. Because of course, when we have these algorithms, they have to have some assumptions, because otherwise it would take too long. So for this assumption, it means that all the energy radiated away in a cone is transported along the central line. So instead of having the whole of the 3D, we have this sort of spikes, only some of the lines, because otherwise it would be too much. So we basically collapse all the energy in one cone onto a line. And this is, of course, a level of accuracy that you can set how big you want the cone to be. But this is beyond the scope of this presentation. But this is just to say that this is the case, and we're going to see that in our simulation. So understanding how it works, now we could get to our experience, because we wanted to try this new algorithm. So we did the first tries in silico on a phantom, and then retrospectively we analyzed our gynecological implants in vivo. So the first step was to try and simulate the easiest case. So the easiest case would be to have, like I said at the beginning, a water-only phantom, like the TG43 would simulate, because the water-only should be, in theory, should be exactly the same as the TG43, because the TG43 only consider water. So then we only put one source in this phantom, and we analyze these isolines. So these isodoses, as I showed you before. So and those legends, the dose, of course, it's higher close to the source and gets lower the farther away you are. So we calculated with the 3 algorithms, with the 2 algorithms, TG43, TG186 standard, and high accuracy. And we can see that there, especially in the lower images, you can see some differences, especially with the green isodose. You can see some spikes. And if we subtract the second images, let's say, with the first, we can have this effect more evident. So if we subtract the 186 dose to the TG43, we actually see all these spikes, and these are actually the collapsed cone approximation. You can see this is called actually array effect. And this is related to a buildup of fluents along the transport lines, along the lines of the cones that I showed you before. So this difference is related to the scatter components. So the scatter, as I said, gets more contribution farther away, so not very close to the implant. And this is why these effects increases in the distance from the center. We have to say that this looks high from the images, but these differences are actually a little clinical importance, because this effect is at most 3% at a distance past the 1% of the dose. So this is really clinically not important, because we are very far from the implant, very far from the source, and the 1% of the dose is very low. So we even if we don't simulate that properly, we don't care, let's say, too much, because it has a little clinical impact. So this was the first case. So we wanted to calculate on the water only. Then we went to see, okay, let's get more complicated phantoms. So we put water and air, different slices, 2 centimeters each, and we wanted to see what changed in this condition. The TG43 is always the same, because of course it does not see the interfaces at all. But the TG186 actually considers the interfaces. And we could see that at the interfaces that are a little different. So the spikes are actually worse. And the high level of accuracy gets it more smooth, because it's able to perform the calculation better. This is, again, the difference in this case actually is the ratio between the new algorithm and the old algorithm, and you can see again these little spikes, but still, as I said, it's below the 5% isodose. So from the clinical point of view, this is really not so important. The next step was to introduce more than one source, because clinically we don't use only one radioactive source. We use multiple position of the source. So the more sources you use, the more complex the simulation gets. But what we see is when you use more dual positions, you actually have less ray effect. So you don't see these rays anymore so much, because they compensate each other. So these the cones that we were talking about before are actually compensated, and we can see them less compared to the one source only. So again, clinically, when we have a lot of sources, we don't have that much of a problem from this point of view. So this is to say that this algorithm is good enough, let's say. So we were ready to say, okay, let's explore the in vivo situation. Of course, retrospectively, because we can't use this algorithm clinically at the moment, but we could recalculate all our patients with this algorithm and see, okay, what would happen if I had calculated with this new algorithm. And finally, I'm going to show you the applicators. So this is called the multi-channel. This is a vaginal applicator, and there are catheters inside. So the source, the radioactive source, can go inside. We connect with some tubes. They're called the transfer tubes. We connect it, and remotely, of course, we push the radioactive source inside these applicators in the vagina or in the uterus, so that the source can actually kill all the tumor cells, and without trying to spare the organs at risk with our plants. So this is what we do. And this is a CT, a part of a CT image. The white is the plastic of these applicators, and the source is inside. So we see the same isodoses that I show you on a phantom, but actually inside the vagina of the patient. So it's actually inside, and you can see this black hole here is a rectal probe in order to remove all the air. And you cannot see properly, but there's also the bladder on top. So this is the TG43. So let's go and see what happens with the TG186. In this case, compared to the phantoms, we don't see that much of a difference, especially because the variations are less than 5%. So there are two lines here, but they're basically one on top of the other. So the only differences actually are where in the black line in the middle, because it's air, so it's different tissue. So that's where the problem of the simulation is. But from a clinical point of view, we don't care too much because it's inside the applicator. So it's not a patient issue. So we don't care that too much. Another applicator that we use is the so-called Fletcher applicator. So it has two ovoids that are pushed on the cervix and the intrauterine device that goes inside the uterus in this case, and the source can go inside. And again, in this case, this is a sagittal view. This is quite nice because you can see the intrauterine device with all the isodoses. So the dose goes directly from inside the patient to the lesion itself. And we see the rectal probe again. And we also see here the bladder field with the bladder applicator as well. Again, even in this case, we see that the differences are less than 5%. But as the paper that I showed you before published, we wanted to see, okay, we use the rectal probe in order to remove air, but what if there was air in the rectum? So we contour the brown, the brown area, which is the rectum, and we say, okay, let's assign air to all of this region. What would happen? And now we see the difference. So if you can see on the rectal probe, you can see that the lines are not superimposed anymore. They are actually slightly separated, which means that the differences are now bigger than 5%. So the 196 actually gives different results. And also in the corona, in the axial view, you can see that there's a difference right in the rectum. So this is quite important because, of course, this underlines the importance of the preparation. Same things with the Venezia applicators. This is quite complicated because it has the channels, but also some needles to add to get more positions. And same condition here. If you don't have air, then the differences are less than 5%. But if you have air, it's actually a problem because it's more than 5%. I put these slides here to say that this calculation took so long. So for one calculation with the new algorithms, it took more than 200 minutes. So still, this is not feasible. Even if you get, now we got an upgrade of the hardware. So it's less than that, but still not feasible for clinical routine because you have to contour, assign slice by slice. It's not easy at the moment. So this is better, but we have to make some changes. But most importantly is this, because the software, when you use it, it actually gives you this warning because the TG186 should only be used for evaluation purposes. So you cannot, at least in Europe, we cannot use this for clinical routine. So we say, okay, we only use for evaluation, but we would like to use it in clinical situations, in clinical practice, because this is definitely needed. So there's a group in ESTRO, the European Group of Radiation Oncologists, that are actually pushing also to have recommendation and to have on the markets algorithms that are able to simulate these problems better, but that would be feasible. Just my last slide on the head and neck, just to show you that in this case, this is a vestibule. It's a very complicated implant, but just to show you that we can treat lots of sites. But in this case, on the vestibule with so many catheters implanted, the time would be too long to calculate. So this would be even worse for other districts. So gynecological is a problem, but also the other ones would be also worse. So we need to go for more accurate dose calculation. The difference are worse when we have air, But still, we need to work on the calculation time and approval, because at the moment we cannot use it, at least in Europe. So we really need to move forward and get the associations to give us and provide us some recommendation to use it in clinical practice, because we definitely have the necessary, it's necessary for better treatments. And with this, I would like to thank you. Grazie, thank you. And I will be ready to answer to your questions if you have any. Thank you.